I know I always say that I'm back now and I won't disappear again, but I really had a lot going on lately. You know, my PC, which had all my information, all the data I had collected, all my notes, all my textbooks that I had amassed over the years, all the notes I had made, all the PowerPoint slides I had made for these particular videos actually crashed. And I didn't get a chance to back up all the new information, so I lost everything. So I've been in the process of trying to recover everything, and I thought, why not just start afresh and do something new? So that's how I wanted to actually give you guys a much more deeper perspective on the channel concerning the topics and the teaching style, because a lot of people complained concerning the previous teaching style in terms of the slides. So I thought I would do more of a whiteboard teaching session. So grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at atrial fibrillation. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you can be receiving such amazing content every time I post. Now this is going to be a whiteboard session, so there are pretty much no slides here. So if you don't have your piece of paper, I urge you, please grab your piece of paper right now. Pause the video, give you some time. And I emphasize, if you haven't subscribed, please, what are you waiting for? Hit the subscribe button. Okay, so great. So remember that the normal heart rate in every single individual is going to be between a specific rate. So let's say we have our heart rate here. So our heart rate is going to be between around 60 to around 100 beats per minute. And remember that anything that is greater than 60 beats per minute, we're going to be referring, anything that's less than, not greater than, less than 60 beats per minute, we're going to be referring to that as a bradycardia, or these are what we call your bradyarrhythmias. We won't be talking about those in this lecture, we'll be talking about them in another lecture. Anything that is greater than 100 beats, we're going to be referring to that as our tachycardia, which I shall abbreviate as a T. So we have bradyarrhythmias, which are arrhythmias where your heart rate is slow, and you have tachyarrhythmias, which are arrhythmias where your heart rate is fast. Now, the arrhythmias could arise from the ventricles, they could arise from the node, they could also arise from the atria. So, key take-home message is that anything that's arising within the atria or above the ventricle, generally, most of these arrhythmias that you're going to be noting that the Curis complex is actually going to be narrow. You're going to get a narrow Curis complex. That's something that's going to hint you that possibly this is a supraventricular type of tachycardia. So they are specifically what we're going to be talking about are the supraventricular tachycardias. And in this particular lecture, we'll be focusing on pretty much a very important type of supraventricular tachycardia that's known as atrial fibrillation, which I shall abbreviate as AF within this particular lecture. Now remember that atrial fibrillation is actually quite common. It's one of the most common arrhythmias, tachyarrhythmias that you actually get worldwide. It's the most common arrhythmia that's going to be seen in clinical practice. Now, remember that you have 4 chambers in the heart. So if I was to draw the heart there, so let's say this is a heart. This is obviously not going to be a diagrammatically accurate diagram, but let's say this is your heart here. And okay, you have that there. So on the top chambers here, those are your atrium. So this right here is going to be your right atrium. So I shall abbreviate that as RA. Then this over here is going to be your left atrium. So I shall abbreviate that as LA. Then of course, you have your ventricles at the bottom. You have the right and the left ventricle. So here on the side, you're going to be having your right ventricle. Then here on this other side, you're going to be having your left ventricle. So remember that in the right atrium, you have a pacemaker here. And this pacemaker is what we refer to as the SA node. So this is what we call the SA node. And this SA node is what generates the impulse. Remember that in between your atria and your ventricles, there's an insulating tissue that is preventing your impulse from moving from the SA node going to be ventricles unless if it's traveling through the AV node. So you have your AV node there. So there are going to be some pathways that are going to be connecting your AV node together with your SA node. We call these as the internodal tract. Okay, and then there's also going to be another tract that is going to be coming and supplying your left atrium over there. You call this tract as the tract of Bachmann, or what we call Bachmann's bundle. So this here is going to be referred to as Bachmann's bundle. Okay, so this Bachmann's bundle, when this SA node contracts, it's supposed to spread the impulse throughout the atrium, and the atrium is supposed to contract as a syncytium. Now, imagine if you have this part of the atrium contracting, another part of the atrium contracting, another part of the atrium contracting, another part of the atrium contracting. It's not feasible. It's sort of like you're in a room of 100 people and all of them are talking. You're not going to be able to make sense of what anyone is saying because there's a lot of noise going on. The same thing is happening. It's like there's a fish that's flopping in the atrium and these muscles are all contracting at different rates, at different speeds. And this is what we call atrial fibrillation. So what you're going to be seeing in atrial fibrillation is that this person is going to be have, number one, a disorganized. So there's going to be a disorganized type of rapid rhythm. And what is going to be characteristic about this rhythm is that it's going to be irregular. Now, this irregularity of the rhythm of the atrium doesn't have any sort of pattern. Because remember, when you have an irregular rhythm, it could be irregular, regular, meaning that the irregularity has some sort of pattern, or it could be irregularly irregular. So in this type of atrial fibrillation, you're going to be having an irregularly irregular rhythm. So it means that there will be no pattern that is going to be there in terms of the heart's beating. And usually there's going to be an irregular rate, and there's going to be a very fast rate. So often when you look at your ventricular rate, so sometimes your ventricular rate could be fast, sometimes your ventricular rate could be slow, but your atrial rate is going to be very fast. So these people are going to be having a very fast atrial rate. And it can be as very fast as between 300 to about 600 beats. And remember, not all these beats that are coming from the atria are going to be conducted to the ventricle. Because if they're conducted to the ventricle and the ventricle is also beating fast, this creates another problem for us. Because remember that the ventricle has to have enough time to fill up. So if the ventricle is beating fast, it means the filling time is actually reduced. If the filling time is reduced, it means the cardiac output is reduced. This creates a problem for our patients. So depending on how many of these rates are actually transmitted to the ventricle, you could have possibly what we refer to as atrial fibrillation with fast ventricular response, and you can have what is known as atrial fibrillation with slow ventricular response, or it could be normal ventricular response. You're pretty much worried about this atrial fibrillation with fast ventricular response because you know that the heart will not have enough time to actually fill up in diastole. Because remember that the atria is going to be responsible for about 20 to 25% kick and add on the blood that's going to be filling up in the ventricles. And because not all these impulses are actually transmitted from the atria to the ventricle, when you actually feel the pulse and compare it to the pulse that you get when you're auscultating the heart, you realize that the pulse that you get when you're auscultating the heart will be much faster than the one that you're feeling in the periphery. So there will be what we refer to as a pulse deficit. Now, in terms of the epidemiology, remember that this is going to be actually increasing with age. So we tend to see atrial fibrillation, number one, in older individuals. And when we actually look at our scoring system, our CHA2DS2 score, we actually see that in patients that are above 60 years, and you can even say patients above 65, the rates of atrial fibrillation, we see it in about 95% of our population. We can actually see, or 95% of patients that actually have atrial fibrillation are above the age of 65. And in those that are actually even above the age of 80 years, these ones actually 10% of them are going to be presenting with atrial fibrillation. So it's quite a common thing. It's actually much more common in males than it is in females for some reason. It's much more common in males than we do see atrial fibrillation in females. But one caveat that you have to remember is that if you actually see atrial fibrillation in females, the risk of complications is going to be a bit higher in females than it is going to be in males. It's actually common in Black individuals it's less common in Black individuals, so it's more common in white individuals. So It's something that's going to be seen in a lot of Caucasians. Apologies for the bad handwriting. And remember that most of these patients are actually going to be at risk, actually do have heart failure. So we actually see it a lot in heart failure. And remember that with heart failure, it predisposes you to actually having atrial fibrillation. And someone having atrial fibrillation, they're going to be predisposed to actually having heart failure. So this is like a vicious cycle that you are creating. It also puts you at risk of having things like dementia. It puts you at risk of having things like strokes. Now, in terms of the etiology, I want us to take a step back a bit to actually take a step back, because this is very important for you to understand. So let's say you have this as your left atrium, because remember, most of these ectopic foci, or most of the places where atrial fibrillation is going to be happening, is pretty much going to be stimulated from the left atrium. So in the left atrium, remember that the left atrium has these 4 openings where you're going to be having your pulmonary veins, and these pulmonary veins are bringing blood from the lungs into the heart. So remember that there are some cells where these pulmonary veins are actually taking this blood and actually entering. There's an outpouching of the atrium, and this outpouching of the atrium is going to lead to some specialized type of cells surrounding these pulmonary veins, and these cells are actually quite sensitive to hypoxia. So it means that if there is actually any hypoxia that is there, you're going to potentially create a reentrant cycle or reentrant current in this particular area that can actually propagate and result in atrial fibrillation. And in other instances, it may be due to actually stretching out of the heart muscle. Anything that is putting strain on the heart would potentially actually result in what we refer to as cardiac remodeling that could potentially result in atrial fibrillation. So we tend to see that in about 15 to about 30% of our patients, actually there is no associated cause. So there's no cause that we actually find. And when we see this type of scenario, this is what we refer to as lone atrial fibrillation. So this is what we're going to be referring to as lone atrial fibrillation, where there is no identifiable cause in about 15 to about 30% of the cases. There are some certain risk factors. I've already mentioned a few of them. One of them that we talked about is age. The other thing that is a risk factor is, of course, hypertension. Another thing that's a risk factor is diabetes. Another thing that's a risk factor is patients that are actually smoking. Another risk factor is those that have obesity. And last but not least, those that have obstructive sleep apnea. So these are patients that are going to be at risk. Now, when it comes to the actual causes of atrial fibrillation, I want you to divide them largely into 2 main groups. You have those that are affecting the heart, so we refer to those as cardiac causes. No need for you to memorize, because this is extremely easy for you to remember. So you have what? You have those that are affecting the heart, which are referred to as cardiac causes, and you have those that do not affect the heart directly. We're going to be referring to those as non-cardiac causes. Now, in terms of cardiac causes, what should you think about? Anything that is actually going to be increasing the left atrial pressure. Anything that's going to be actually causing a stretch in the left atrium will potentially actually result in atrial fibrillation. So pretty much you're thinking, what could cause the atrium to be stretched out? Maybe it's because there's a lot of fluid that is present in the atrium. What can cause a lot of fluid to be present in the atrium? Remember that the left atrium is going to be pumping to the left ventricle through the mitral valve. So if this valve has a problem, maybe they have a valvular disease, it means that there'll be more fluid that remains in the left atrium. So for example, in patients that actually have mitral stenosis, so in your patients that have valvular heart disease, such as mitral stenosis, and remember this could be in the background of a patient that is actually having rheumatic heart disease, these people could actually possibly be presenting with, of course, your atrial fibrillation. In addition to this, you also have patients that have hypertensive heart disease. So those that have persistent hypertension and those that have now developed hypertensive heart disease. Because remember that hypertension is going to be putting stress on the myocardium, and this repetitive stress on the myocardium and even this repetitive activation of the renin-angiotensin-aldosterone system ultimately will result in remodeling processes that we actually see in the cardiac tissue. And these remodeling processes are going to cause, eventually there'll be first left atrial hypertrophy, which will eventually progress to left ventricular dilatation. Eventually this atrial remodeling predisposes the heart to develop of course, your arrhythmias. It could be in the background of patients with congestive heart failure. So remember, like I said, congestive heart failure is of course a risk factor for atrial fibrillation. Atrial fibrillation is a risk factor for congestive heart failure, especially those that have diastolic heart failure. For those with diastolic heart failure, they're at increased risk of actually developing atrial fibrillation. It could also be in patients that are having inflammatory pathologies. So they could be having an inflammatory pericarditis, for example, and this can be a cause of your atrial fibrillation. Then your non-cardiac causes, think of things that can cause hypoxia, think of pulmonary disease. So anything that is causing, for example, a mismatch in the ventilation to perfusion ratios. So it means we can see our atrial fibrillation in patients that have pneumonia because of the ventilation to perfusion mismatch. We can see it in patients that are having COPDs, especially those patients that have chronic bronchitis. So for those patients that have chronic bronchitis, we can see the non-cardiac causes resulting in atrial fibrillation. It could be also in patients that are having a pulmonary embolism, a PE, because they're also going to be having this ventilation to perfusion mismatch. Then you also have others. So these things could be things that are actually increasing the adrenergic drive, the adrenergic input. So it could be things that are stimulating your beta-1 receptor. Remember, when your beta-1 receptor is stimulated, this leads to positive inotropy. This leads to positive chronotropy. This also ultimately leads to increase in atrial ectopy. So this is ultimately leading to atrial fibrillation. So it could be things like sepsis that could be triggering this. It could be things like post-operative states. So people that are coming from theater, because remember we see the atrial fibrillation in about 30% of the cases. It could be for those that have tumors. For example, those that have pheochromocytoma. So I don't know if it spells pheochromocytoma right, but those that have pheochromocytomas possibly could present with atrial fibrillation. It could be also those that have thyroid disease, those that have thyrotoxicosis. Any of those causes of thyrotoxicosis can actually result in your atrial fibrillation. So there is a mnemonic that you can actually remember. I'm not really a big fan of mnemonic because you get to the exam, you remember the mnemonic and you forget what it actually stands for. But you should remember the mnemonic PIRATES. For those that actually love mnemonics, you can actually remember the mnemonic PIRATES. So the P is going to be standing for pulmonary disease. The I stands for infections or sepsis. The R stands for remodeling, so it should remind you that there are some cardiac diseases. The A stands for alcohol. Alcohol is one important thing I forgot to talk about. There's something that's known as holiday heart syndrome. Because remember that alcohol intake becomes a bit more evident, especially during the holidays, during those special festive seasons. And remember, the alcohol puts you at risk of many different types of arrhythmias. One of the common arrhythmias that we actually see with alcohol intake is, of course, atrial fibrillation. We also have T for thyrotoxicosis. And of course, the pirate, which is E here, this should stand for electrolyte imbalances. So electrolyte imbalances like potassium, hypokalemia, as well as magnesium, hypomagnesemia could actually put you at risk of this. We also have some drugs under other causes here, some drugs, sympathomimetic drugs. You could also have things like PCP, you could have methamphetamines, you have cocaine, even caffeine can actually result in atrial fibrillation. In terms of the classification, your benchmark is pretty much 7 days. So for those that are having atrial fibrillation for the first time, that they haven't had any symptoms and they have presented with symptoms of atrial fibrillation for the first time, we refer to this as paroxysmal. So this is what we refer to as paroxysmal atrial fibrillation. And these ones, especially those that are actually presenting within 48 hours, less than 48 hours, these ones are going to be good candidates for cardioversion. You can actually cardiovert them. You use a defibrillator, synchronized direct current cardioversion. You can actually synchronize and cardiovert them back into sinus rhythm. Even if they're hemodynamically unstable, there's no risk that there's a thrombi that has formed because, of course, they're presenting within 48 hours. The risk of a thrombi already forming is actually less. Then for those that are above 7 days, for more than 7 days, we now refer to these patients as having what is known as persistent atrial fibrillation. Persistent atrial fibrillation. Then for those that are actually having it for more than 7 days, to about a year, to more than a year, 1 year. And you may sometimes, even in these patients, attempt not to ablate them, not to actually take them for some sort of definitive therapy. We refer to these ones as having a permanent atrial fibrillation. And remember, this is very important because the longer a patient is actually in atrial fibrillation, the harder it will be for them to actually convert to sinus rhythm. So if they present quite early to your facility, within 48 hours, you want to aim to take them to your sinus rhythm. We'll talk about the strategies of how you can actually take them into sinus rhythm. In terms of the clinical features, most of our patients are going to be, they can be asymptomatic, but if they have symptoms, they're obviously going to present with symptoms such as chest pain is one thing that they're going to be presenting with. Palpitations is another thing that they're going to be presenting with. And then they may have shortness of breath or dyspnea, and they may even have fainting episodes. They may have some signs. One sign that will point you is that they'll come in with an irregular pulse. So they'll come in with an irregular pulse, and remember that the irregularity of this pulse is going to be an irregularly irregular pulse, and they're going to be having what is known as a pulse deficit. And then remember what a pulse deficit is, as I said earlier on. If you check the pulse when you're auscultating the heart, compare it with the pulse from the, for example, the radius, you're going to realize that the heart rate from the auscultation is much faster than what you're palpating. So that's what we refer to as a pulse deficit. These are some of the features that you should actually look out for. They may have some other features that may be pointing towards other abnormalities and other related underlying disorders. In terms of investigation, one primary thing that you want to do is an ECG. Remember, having a normal ECG does not rule out atrial fibrillation, because in some cases, they may be in paroxysmal atrial fibrillation where it actually reverts back to normal. So if there is some suspicion that there could be some atrial fibrillation, what you could possibly get is what is known as a Holter monitor or a Holter ECG. Now, this Holter monitor is what is going to be placed on the patient for continuous monitoring of the ECG. It's able to actually pick up some of these arrhythmias. But when you get an ECG for this patient, what will be the striking things? Of course, your rhythm will be irregular. And remember that the irregularity of this rhythm is going to be irregularly irregular. So it will be an irregularly irregular rhythm that's going to be pointing you towards an atrial fibrillation. There'll be no P waves, so you won't be able to see any P waves that you can discern on your ECG. So when you actually draw out your ECG, because remember that your ECG is going to be having a P wave over there, and then you have your QRS complex like that, and then of course you have your T wave, and then your P wave again, your QRS complex, your T wave. That's what a normal ECG will look like. Now, an ECG of someone who's having atrial fibrillation, so you're going to be having these small waves, and all of a sudden, the QRS complex, small waves. They may be close to each other. Small waves, the QRS complex, small waves. So there are no discernible P waves that you can actually see on this. And sometimes it could be a fast heart rate. We call that as a atrial fibrillation with a fast ventricular response. So it could be a slow heart rate or normal heart rate, atrial fibrillation with slow ventricular response. You're better off getting an atrial fibrillation with slow ventricular response to allow your heart to actually fill up with blood. So that's one investigation that you can actually do. A second investigation that you can actually do is an echocardiograph. And remember that in terms of echoes, there are predominantly two main ones that you could do. You can do what is known as a transthoracic echocardiograph, which is known as a TT, or you could do what is known as a transesophageal echocardiograph. So your transthoracic echocardiograph as well as your transesophageal echocardiograph. You want to do your transesophageal echocardiograph, because remember that your transthoracic echocardiograph may sometimes not be able to look at the left atrial appendage. That is possibly the place where you get a lot of these blood clots, but your transesophageal echocardiograph will be able to pick this up. So if you have a transesophageal echocardiograph, you're better off getting a transesophageal echocardiograph. You also want to look at the ejection fraction of this patient. You want to look at the diameters of the chambers to look for any possible left atrial dilatation or enlargement, and of course any other structural defects that may point you towards an underlying cause. You also want to order your thyroid function tests, because remember we said that those thyroid disorders could possibly result in atrial fibrillation. You are going to be also ordering your cardiac enzymes for this patient, your cardiac enzymes, so that's your troponin T, your troponin I, your CKMB. They're also going to be ordering your electrolytes. Because remember that we say that in terms of the electrolytes, you have potassium and you have magnesium, hypomagnesemia, hypokalemia that could possibly result in atrial fibrillation. You also want to get a chest x-ray for your patient. So these are your basic investigations that you're going to be ordering for your particular patients. Now, in terms of treatment, there are some goals of treatment that you should actually think about. So the first is what's known as the rate control, okay? So RT, rate control. And the second is what's known as the rhythm control, RHC. And of course, you're going to be considering your anticoagulation. So your anticoagulation. So your rate control, you're aiming for a heart rate that's at least less than 110 beats per minute in your rate control. In your sinus rhythm, you're going to be aiming for, or rather a rhythm control, you're going to be aiming for a sinus rhythm. Then of course, in your anticoagulation, you're aiming to prevent or reduce thrombi. So you're aiming to prevent and reduce thrombi or embolism. So we'll begin with rate control. So here, what we're dealing with is actually just slowing the heart down, because remember, we want the heart to have enough time to fill up with blood. So there are ways in which we can do this. There is drugs that we can actually give. There are drugs that we can actually give these patients. So one group of drug is known as the beta blockers, which is the first line of treatment in most of your patients with atrial fibrillation, those that are not in heart failure, those that don't have a structural underlying defect. Your beta blockers are quite good. So these are drugs like bisoprolol, these are drugs like metoprolol, these are drugs like carvedilol. Now remember that the caveat that's going to be there for beta blockers is that you're going to be avoiding these drugs in patients with acute heart failure, you're going to be avoiding these drugs in patients with bradycardia, you're going to be avoiding these drugs in patients with COPDs. So beta blockers, avoid them in those groups of patients. In diabetic patients, remember that they do have a risk of hypoglycemia, especially in those patients that require insulin. They also mask hypoglycemia, so they should be used with caution in patients that have diabetes. Then you could sometimes use calcium channel blockers, your CCBs, and remember these are your cardioselective calcium channel blockers. Only two drugs that I want you to remember, verapamil and diltiazem. These drugs are also avoided in bradycardia, but we also avoid them in acute heart failure. So your beta blockers and your calcium channel blockers, avoid them in acute heart failure because they will increase the risk of mortality. Then in terms of your third group of drug, these are your cardiac glycosides. So pretty much the drug is going to be digoxin. And often digoxin is going to be used for rate control, especially for those that have atrial fibrillation and those that have heart failure with reduced ejection fraction, especially those that have a heart failure with a ejection fraction that is less than 35%. And you can actually aim to use digoxin. So your aim is to actually drop the pulse rate and ensure that the rate is less than 110 beats per minute. So it means that possibly there are some patients that you could actually receive with certain comorbidities. For example, someone comes in with atrial fibrillation and they have maybe thyroid or thyrotoxicosis or Graves' disease. It means your drug of choice in this case would be a beta blocker because it will work for both the heart, it will work for the thyroid disease as well to minimize those symptoms. Then if your patient has come in now and they're in systolic heart failure and they have atrial fibrillation, remember you want to use your digoxin. Then if they come in and they have asthma or COPDs, you want to avoid your beta blockers, you want to avoid your digoxin, this is when you could possibly use your calcium channel blockers. So that's with rate control. Then in terms of rhythm control, there are two strategies that you could actually use. So we could actually use drugs, which is what we refer to as the pharmacological strategy, or we could use the defibrillator, which is what is known as the non-pharmacological therapies. So in terms of your pharmacological therapies, usually the drug that I want you to keep in mind is a drug that's known as flecainamide, flecainamide, F-E-C-A, flecainamide, like that, flecainamide. So this is one antiarrhythmic that you're going to be using. We're going to be looking at antiarrhythmics in another video, but this is one antiarrhythmic that you should use. But remember that we should avoid this antiarrhythmic if there is structural disease. If there is structural disease, another antiarrhythmic that you could use is amiodarone. But remember that with amiodarone, you also avoid it in patients with thyroid disease. Avoid amiodarone because it has a potential to actually cause thyroid disease. Now, these drugs actually are not really so good for our patients. Why? Because they are going to be increasing your QT interval. And remember, once you increase your QT intervals, it means it predisposes your patients to your torsades. So it predisposes your patient to your torsade point. So that's not really a good way to actually deal with your patients. So for your patients that come in now and they are hemodynamically unstable, their BPs are low, they are in significant respiratory distress, they're about to die. These are patients that you want to defibrillate. So now when you do your non-pharmacological therapy, you can defibrillate your patients, and you call this as direct cardio defibrillator, direct cardioversion. This is a synchronized cardiovert. So this is where you shock your patients. If they're hemodynamically stable, it means you have time to actually get a transesophageal echocardiograph and actually ensure that there is no thrombi. If there's a thrombi, you anticoagulate them first, then you defibrillate them. But for those that are hemodynamically unstable, you could defibrillate them even without having done your echocardiograph, because the risk of them dying is much higher than the embolism that you're actually going to cause. So for those that are hemodynamically unstable and they are presenting with atrial fibrillation of unknown duration, you could actually anticoagulate them for about 3 to 4 weeks before you actually decide to defibrillate them. Then there is also some surgical means where you can actually take your patients for radiofrequency ablation, or you can do what is known as a maze procedure, where they build this sort of like a cage to contain, or they create this cage to contain this electrical impulse so that it's conducted in the right way. So I'll give you some clinical vignettes, and I want you to pause the video so that you can see if you're following with the lecture. So let's say you get a patient that is unstable, hemodynamically unstable, they're in hypotension and they're in shock, or they have heart failure, or they have myocardial infarction. What are you going to do for this patient? If you say that you're going to cardiovert them, you are indeed correct. So it means that this is a patient that needs to be cardioverted. You're going to give you a synchronized shock of about 120 to about 150 joules of your shock. You may or may not consider to give them amiodarone, depending on whether they have some structural abnormalities or they don't. Then if your patient now comes in and they're stable, they have atrial fibrillation that's less than 48 hours, what are you going to do? Of course, you can choose either your rate or your rhythm, but you're better off choosing your rate. So you control your rate, or you can control your rhythm. Your rate could be controlled with beta blockers, calcium channel blockers, or digoxin, depending on the scenario. Your rhythm can be controlled by your drugs, or it can be controlled by your cardioversion or your surgery. And for your patients that are stable and have atrial fibrillation more than 48 hours, these are your patients that you actually want to prefer the rate control for them. These are patients that you want to give either your beta blockers or your calcium channel blockers or your digoxin. Then, of course, catheter ablation could be done for those that are having this atrial fibrillation that is starting off from the pulmonary veins, that area that I talked about earlier on. Remember that all your patients, or most of your patients, should be anticoagulated, because there is actually a risk of complication. And what actually denotes this risk of complication is what we call our CHAD-VASc2 score. So your C stands for congestive heart failure. So if they do have congestive heart failure, give them 1 point. Your H stands for hypertension. So if they do have hypertension, we give them 1 point. The first A is for, or the first A, the CHAD2, is if they have an age greater than 75, you give them 2 points. And then the D is for diabetes. So if they have DM, you give them a score of 1. The S, the CHADs, remember CHADs, the first S is for a stroke or a TIA, you give them a score of 2. Your V is for your vascular disease. If they have peripheral artery disease, previous myocardial infarction, and aortic atheroma, you give them a score of 1. The A is for age. If they have an age between 64 to about 74, you give them a score of 1. And then, of course, the last SC is for sex category. So if they are female, you're going to be giving them a score of 1. So you add your total score. Now, if your score from your CHAD-VASc2 score is 0, so there's low risk of them having thrombi. So these are patients that you could actually just possibly put on aspirin. So you just put them on ASA to prevent the stroke. If your patient has 1, these are those that have intermediate risk. So these are patients that you consider giving your aspirin, and these are patients that you may also consider anticoagulating if there are no contraindications to anticoagulation. Then for those that have 2 or more, these are definitely need anticoagulation. So these are going to be given anticoagulation. And then remember that in terms of your anticoagulation, you could use, for those that have non-valvular atrial fibrillation, you could use your DOACs, your direct oral acting anticoagulants, so drugs like rivaroxaban, drugs like apixaban, drugs like dabigatran. And for those that have the valvular or non-valvular atrial fibrillation, then if they have CKD, chronic kidney disease, you could use your warfarin. But remember, with warfarin, you have to be checking your INR every week and ensure that your INR is between 2 to 3 if they don't have any mechanical valves, and 2.5 to 3.5 if they have some prosthetic valves. Then remember, for those that are hospitalized, you can start them on your Clexane and then bridge them to your DOACs or your warfarin. Then in terms of complications, lastly, remember that there could be a thrombi that forms in the heart, and this thrombus can actually dislodge. And if this thrombus dislodges and goes to block the brain, it could cause a TIA, it can cause a CVA. If this actually dislodges and goes to block the superior or the inferior mesenteric artery, this could cause acute mesenteric ischemia. So this is not acute myocardial infarction, but this is acute mesenteric ischemia. So it could cause acute mesenteric ischemia. And remember that this is going to be presenting with your abdominal pains. It is going to be presenting with ischemic colitis in some cases. It could sometimes block the vessels in the limbs, so it could produce with acute limb ischemia. This is not acute lymphoblastic leukemia, but acute limb ischemia, where there is intense pain in the leg and of course there's decreased pulses. The patients with atrial fibrillation could have heart failure, because remember that I said heart failure is a risk factor for atrial fibrillation. Atrial fibrillation is a risk factor for heart failure, especially those that have atrial fibrillation with fast ventricular response. These are your patients that are going to be having this heart rate that is very fast. It's not giving enough time for the heart to fill up with blood, such that your end diastolic volume is reduced, the stretching of the myocardium is reduced, your preload is reduced, your contractility of the heart is reduced, your cardiac output is reduced. Ultimately, your BPs will be low, and ultimately, these are your patients that are actually going to be in shock. These are your patients that are going to become hemodynamically unstable. Then sometimes this thrombi can actually dislodge and actually go and block the pulmonary vessels. So it can actually result in a pulmonary embolism. And then in addition to this, you may sometimes have the heart failing. And remember, once the heart failing, there can be backflow of this blood into the lungs. And once there's backflow of this blood into the lungs, sometimes these patients could actually present with pulmonary edema. So remember that this is potentially going to be worsening. There's decreased filling of the ventricles, there's backflow of the blood into the atrium, backflow of the blood into the pulmonary vasculature, increase in the capillary wedge pressure, leakage into the alveoli, causing alveolar edema, leading to a ventilation to perfusion mismatch. This can actually increase your work of breathing. It can cause hypoxemia. So generally, if your patient has the signs of these complications or they're in shock, this is what we refer to as hemodynamically unstable atrial fibrillation. Those are the important things you need to know in relation to atrial fibrillation. I really hope you enjoyed this lecture. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.